Fuck. There's Marco.
Good morning, John.
How you doing?
I'm doing well so far.
Hey, we rescued a Russian webcast this morning because they didn't set it up right. And I was talking to Hey, Nick. I was talking to Nick. I was talking to Borba, and he set it up. Here, let me get this. I'm getting confused here.
Hello, dear John.
Hey, Nick, how you doing?
Okay, I'm very well. Greetings from the hot Thessaloniki in Greece.
It's always hot there. Theo Niki. Hey, this is Marco. This is Nick. He's a loyal follower of Neurosurgical TV.
Hello, Marco. Nice to meet you. Greetings.
Hello, sir.
Okay, you have to excuse me for a minute, gentlemen. Okay, I got to do some stuff.
The friends of John are also my friends.
Oh, thank you, sir. I say the same.
Okay.
Yeah. Greetings, everybody. Is there anybody? There's Marco. Marco, I think the way I would like to see it work, I mean, ideally, is to someone like you that's in the waiting room like now, because people will come in and like Nick and want to talk like this show. Hello, how you doing? Are you Madalena?
Hello, yes, I'm Madalena.
I can't hear you.
I don't know
Is
if
it me or your?
Is it okay? You can hear me?
Can you hear okay, Marco?
Yeah, yes, quite perfect.
It
Yeah.
must be
Thank
my, hold on. Can you talk some more?
Hello,
Nice
Go
to
ahead.
meet you, Miss Melina.
you can hear me?
Yes,
Yeah.
yes.
Okay, yeah, it's my headphones. It's my headphones. How you doing?
Hey, hello, I'm fine. How are you?
Good, I'm John Bennett. And
Nice
this
to
is
meet
Marco. He's going to be the neurosurgical guy. Like, I'm off the camera in the back and Marco's going to say, hi, I'm Marco from Cuba, and describe himself. We have the pleasure of having on Neurosurgical TV. He is Neurosurgical TV, okay? And then I'd like to introduce Madalena Popescu. Is that how you say it?
Yeah, it's fine.
Okay, Marco, learn how to say that name. I'd like to introduce her, and she is basically going to run the show, okay? And after
Okay.
that, we
nice to
stay
meet
off
you
the
all.
camera. It's your show, okay?
Okay.
It's a lot of
Thank you so much
responsibility. The
for-
Western
for
world
this.
is counting on you. Romania is counting on you.
Yeah, thank you so much for this collaboration. It's truly an honor to meet you all, and I hope everything will be all right. I think my name is not right because I entered from Elena's link.
Yeah,
And,
you know how to change the name?
I
Go
don't
up,
know how
go
to
up
change
to the
it.
right corner of your screen. You see next to the mute
Okay.
button, open that menu and
Name.
it'll
Oh,
say,
okay.
rename.
So,
Okay, it's,
Miss Madeline is Madeline.
Yeah, Madalena. Or
Madalena. Okay, so
Yeah.
you're originally from Romania, right?
Romania, yes, Bucharest.
Okay, okay. Nice to meet you. My name is Marco. I am a Cuban neurosurgeon. And by the grace of John Bennett, I'm working with Neurosurgical TV and him. He gave me this amazing opportunity to work with Neurosurgical TV. And yeah, I have the honor to be the host, or not the host but like a collaborator from this amazing platform.
Yeah,
So
start a dynamite group, Cuban Neurosurgery, Cuba Grand Rounds. It's going great. It's going great.
so you are invited, obviously, anytime you want comes to our Sundays. We do Sundays rounds from Cuba where we like to
Go
share.
ahead, screen share it, Marco. Be aggressive, be pushy.
I just want to be humble at the first.
No, that's okay. No, you can show it on cam. I find that it helps a lot when you share stuff on the screen.
Yes,
You
yes,
know,
of course.
even during informal conversations.
Yes, so please just
So
share
do you know Francesca?
Yes, of course.
Oh, she's a troublemaker. Oh, she makes trouble.
No, she's not.
Wherever she goes, trouble follows. You know that, right?
She's a wonderful person, and
She's a troublemaker.
We collaborate with her.
So we had fun. We did a few webcasts. You probably saw them a few years ago. They did a webcast on how to set up a Walter Dandy. I don't know if you saw that. Elena did that webcast a couple of years ago. It's on the link in the.
Yes, I've seen them.
And you might have to touch base with Iype. Madalena, you might have to touch base with Iype to make sure, because he
Yes,
does a lot of lectures, you know? And he might get confused, and you might have to send him the link. Okay?
of course.
You got his contact, right? You probably WhatsApp. Yeah, it was great. Barbara was on. I could see him in the Zoom. I went into the Zoom in Russia and I knew it was running, but it wasn't on YouTube. So I text Barbara, who was on the screen, and said, "Hey, Louis, tell Sufinov, who doesn't know much about computers, he's a Russian neurosurgeon, to go to the menu at the bottom of the Zoom, click on the let access to YouTube," and that was it. He did that, and it was live on YouTube. So we saved that, and it went live. Hello, Anna Maria.
Hello.
How you doing?
I'm doing well, thank you. And you?
Good. I'm John Bennett of Neurosurgical TV. This is Marco from Cuba.
Hello,
Nice to
it's
meet
really
you.
nice to meet you all.
Nice to meet you too. It's really incredible, John, what this platform is actually doing. That being able to bring all the neurosurgeons or the students or even the residents to the neurosurgical world, which is really is
Well,
really amazing.
of course, it's educationally valuable, but it's fun. It really is fun. I mean, it's a good one. I mean, education sometimes gets a little boring, but I think this is fun, meeting people and going different parts of the world. We haven't been to Romania for a while, but we go to a lot India today. Today's India and Brazil. I've already been to those, and Russia. So, I mean, to jump around like that for an old guy like me is good. Let's see. Okay, there's Nick. Well, I got it on the. Okay, the way I usually do it, Madalena, when Marco turns it over to you, okay, then you do everything. You introduce Iype,
Okay,
and
that
then you
sounds
handle
perfect.
the questions. I don't know how Iype wants to do it. It's, because some speakers will let you interrupt them for questions. Other speakers prefer you wait to the end. So whatever you two guys decide. And then you handle, just like a medical conference in the hospital, you handle moderate. You know how you've done that before, I'm sure.
Of course, we had many activities this year, and I hope we'll collaborate next year for especially for the international speakers that we have. We had some speakers from Stanford, and there were amazing events, and I'm sure it would be amazing collaborations with you.
Well, I'm sure it will too, but I try to impress upon Marco that you can reach anyone in the world now. It's opened up. I mean, you have access to the top neurosurgeons in the world. Top. I mean, there's other valuable ones, but I mean, you have access now to the top, and that has never happened in history before. Of course, we didn't have the computer, but you'd never meet someone like Lawton or Iype, never. Maybe you got lucky once at a conference or something like that. But you guys, you probably don't realize how lucky you are, but you are.
Yes, we are. And all these online events brought us so many opportunities. And we must be
Yeah, you guys, well, you guys grew up with tech, you know, especially social media. What social media is popular in, we got some background noise here. What social media is popular in Romania?
Mostly Instagram.
Instagram?
Like it's more popular than Facebook now. And we connect with our participants mostly on Instagram. Any questions, anything that appears, we talk with them.
Yeah,
there.
I've got to get friends with you on Instagram. I'm just starting to learn Instagram.
Yeah, we keep our Facebook alive too, and we post there everything, and it's okay.
Yeah, I'm used to Facebook, which I use a lot. It's very useful. I mean, I think a lot of people have gotten away from Facebook in America, but not the medical community, especially in South America, Europe, Africa, and India. Facebook is still strong in neurosurgery. I know the kids are going other places, but in neurosurgery, I find that it's pretty, it contacts a lot of people. Who else we got in the audience here that wants to say hello?
So we'll have two speakers from our members. One is Ana Maria Zidaru, and one is Ana Maria Dragan, with her camera on.
Oh, welcome.
Thank you.
They'll make a small introduction in the field of.
Well, that's the part you run. You run that. You coordinate that.
Of course.
You know what happens sometimes, Madalena, when I try to moderate, I'm doing other stuff like promoting and stuff like that, and I don't pay attention. And so I'll come back and I'll see a question, I'll ask it, and they'll say, we just answered that.
Okay, sure.
So I prefer to have someone like Marco host, so they can pay attention to the flow, you know, the flow of it and how it's going.
Yeah, I'm actually trying to do some posts with the late countdown.
Oh, Afghanistan, we have a neurosurgeon from Afghanistan. I hope we get to talk to him before we start. Come on. I bet you guys have never met a neurosurgeon from Afghanistan. Ahmad, are you there?
I personally didn't. No.
He comes, hey, Ahmad.
Hi, hello. Hello, Professor.
Yeah, say hello to the eager Romanian neurosurgical medical students.
Yes, sir. Okay, thank you. Nice to meet you.
Nice to meet you too.
Thank you.
Can you introduce yourself, Ahmad? Can you tell where you work and where you are and stuff?
Yeah. I'm Dr. Ahmed Fawad Pirzada, neurosurgeon from Afghanistan, and also president of Afghanistan Neurosurgical Society.
Okay, and we're going to do soon an Afghanistan Grand Rounds.
Yes. We will do it as soon as possible, yes?
Yeah, whenever you're ready.
Okay.
And we can always practice too, if if you feel unsure and you want to get a better hold of it.
Yeah. Okay, thank you.
And maybe you could be a speaker for Romania sometime, if you ever need a speaker or whatever.
Okay. And
very good.
we are looking for also that how Romania help for Afghanistan.
I'm sorry, I didn't understand.
Yes, no. I thought that's how Romania help for Afghanistan neurosurgery.
You're the only one I've met from Afghanistan. Is that what you're asking? Yeah, you're the only one I've met so far from Afghanistan.
Okay.
Iraq, we've had a few grand rounds from Iraq. Iran, no, not yet, but we will eventually. So we'll see. So how are you? You're very busy now?
Yes, sir. Yeah.
Did you see the military trauma show we had, the webcast?
Yes, yes, we have a lot of cases, trauma and military trauma, suicide bombers, explosion,
Yeah,
and yes, assault cases as well.
yeah, penetrating missiles. You
Yes,
know, Iraq is, Ukraine's going to continue with their webcast.
Yeah. Yes, I was with Iraq as well, and with Ukraine as well.
Well, you know, maybe you could present at that military neurosurgery if you
Yes,
wanted
yes.
to. If you,
Yeah.
I'll keep that in mind. Would you like to present at that conference?
Okay, yes, sir, yes, okay.
Okay, great. Okay, it's
Thank you.
in a couple of weeks. I'll send in the information. You see how this
Okay.
works, guys? Marco?
Yes,
Yeah.
it's incredible all the net.
Well, you see how it works. We just got a speaker for Ukrainian grand rounds right there, a relevant speaker is in the field of military neurosurgery, because obviously
Yep.
there are injuries more particular to that branch than other branches. So that's great to have an experienced neurosurgeon speak.
That's the important, John, of this platform you created. So it is already worldwide. Is able to reach every corner of the world. So I think that's the main importance of your work.
Yeah, that's becoming more of a reality. You can see the internet improving, especially Wi-Fi, in parts of the world that were not very good before. Julio Cesar Cortez, buenos días, ¿cómo estás? De México. ¿Puede hablar, Julio?
Hi, hello. How are you?
¿Cómo estás?
John?
How you doing?
Muy bien, gracias.
Bienvenidos.
It is a pleasure to know different points of view from this important canal and from the world with Professor Marco from Cuba and Afghanistan, and now with the student with Romania. It's a great pleasure to get in contact with them and with
Romania,
you. Thanks, John.
Afghanistan too.
Thank you. Actually, I can speak a little bit Spanish too. As we were saying, John, this Sunday we will have the 4th Cuba ground round. So please, all the attendants today and the panelists, feel free of coming tomorrow to see our ground rounds. It will be in Spanish, but it will be like a Spanish class to everyone, and it will be an amazing.
Well, you know, we can announce that. Like when I was in Russia this morning with Borba, I texted to him, announce the Iype Romanian Walter Dandy show, but he didn't. He's scared. So, but you can do that. I mean, you can do that.
It would be amazing
and if you can remember, I'll remind you. I'm sorry to talk over you there, but I'll remind you that, hey, announce the Cuba Grand Rounds at the end of this show. Just say tomorrow, I'd like to make an announcement. I'll remind you before we finish.
Okay.
Make an announcement and screen share it. Okay.
And also,
and go over the speakers. When you introduce the speakers, explain why they're good and why people should watch it.
Okay, and I'm also doing all the arrangement for the Latin American ground round we were talking about yesterday. I already spoke to Raul Echeverry, and he said that he is on it. And also I spoke to a few neurosurgeons from Ecuador and also from Colombia. They are going to give me the final decision this Monday. So I'm doing all the arrangement for it. Good.
Because now it's time we've got a way to do it to establish it. It took a while to figure that out, and trial and error and watching other people and stuff like that. But I think we have a really good solid shot, especially Costa Rica and you know, Ecuador, Colombia, those big countries. Small ones, we're going to have a hard time, but the rest of the country should be fine. So does anybody else want to say hi before we start? Yeah, a lot of people prefer
I
to
don't
keep
think
quiet.
Professor
Oh, go
Iype
ahead, go ahead.
I don't think Professor Iype is in this meeting right now. I'm trying to contact him.
Okay,
And,
I'll
Elena, of
contact him
course.
too, okay?
Yeah, so we'll have to wait some minutes.
Okay.
I'm so sorry.
Or did you talk to him or no?
So Elena is the one talking to Professor, and she's contacting him right now.
Okay, I'll send him a link, okay?
So yes, perfect.
I'll also try to contact him. Okay, what does what does Elena say? Does she say anything?
Yeah, she's talking with the professor right now. Oh, it was a misunderstanding about the hour of the event. So yeah. So it's gonna be all right.
Oh, so he was surprised.
Yeah, I don't know. He actually thought this event was supposed to be yesterday, and yeah, everything will be all right.
Oh, okay. Well, if you have to I hope you don't have to cancel. I hope not.
No, of course not.
Hey, Margarita. Can you hear me, Margarita?
Yes, hello, I hear you.
Oh, okay. Okay, good. How you doing? Marco, ¿tú conoces María?
Margarita or
Margarita,
yes,
sí, Margarita
yes.
de Madrid.
Yes, I had the
Yes.
pleasure. The last Cuban ground round. Hello, Margarita. Hola, Margarita.
Hello, Marco.
Excuse me, Marco, your banner is backwards.
Yes, Marco is tomorrow. Tomorrow, we have conference.
Oh, sí, realmente décanos saber de eso.
Yes, Margarita. Tomorrow we have the fourth Cuba Ground Round. Mañana tenemos la cuarta.
Excuse me, Marco, your banner is backwards. Your banner is backwards.
It's backward?
Yeah, you gotta turn it.
Let me try to fix it.
Yeah, you go into the settings for that. Hello, Elena.
Yeah. Hello, everyone. Nice to meet you.
How you been?
Very good, thank you. How have you been?
Good, good. As long as that troublemaker stays away from me.
And very busy.
Oh, good, good, good. Can you answer a question, Elena, for me?
Yes.
Is Francesca causing a lot of trouble?
No, she's solving a lot of problems, actually.
She's a troublemaker.
She's a problem solver, I think.
She's a big problem.
Solver, not maker, solver.
Yeah, I know. I just joke. She's funny.
Yeah. So we are waiting for Professor Iype Cherian to join us any moment now.
Yeah. Oh, okay. So you were in contact with Iype?
Yes, yes.
Okay.
He's gonna be with us any minute now.
Okay.
And
okay.
I want to officially thank you so much for helping us broadcasting the meeting tonight.
Yeah, sure, sure. Well, listen, here's how Marco is going to be Neurosurgical TV. Marco, say hello to Elena. She was the past president of Romania, Walter Dandy. He's going to introduce Madalena. And where it goes from there, it's totally up to her, okay?
Perfect, perfect.
Okay, Elena?
Yes, okay for me.
Okay. So you're not speaking at all? No, maybe not. I don't know. Whatever.
So I want to thank you everyone for joining us today. This is a topic that I'm very, very interested in. And it's been something that I've been working on lately and presented during a neurotrauma course that was held here in Romania this April. And I was very surprised to see that I was met with a lot of restraint, so to say. It seems like the idea of cisternostomy is not very popular in Europe. And I am very keen trying to continue on this path. And hopefully, as time passes and more evidence will be published, people will understand that this is the way to go to perform modern neurosurgery and bring modern techniques into neurotrauma care.
Yeah,
I see Dr. Giacomo Bertolini is online now.
Still backwards. Marco, it's still backwards here. Excuse me. Yeah, you just go into the settings. Let me explain how to get in there. Yes, yeah, it's better not even be. Is it on there? Let me see you here. Okay, yeah, that's fine. It's better than backwards.
Can you see it now, John? The banner?
Yeah, it's good now. It's good now.
Okay.
Yeah. Perfect. So have you, well, Elena, where have you applied for residency? Where are you going to go, or?
Yes, so right now I am a second year neurosurgery resident in Bucharest at Bagdazar Arseni Emergency Hospital.
Okay.
And the future looks promising.
Good, good.
I'm just
good.
starting. I'm junior, but I'll keep you updated.
Good. Well, congratulations on your wedding.
Thank you.
When are you getting married?
When? In August. In August this year.
August, okay.
Yeah, so 2 months to go.
Is he in neurosurgery or?
Thank you. I'm sorry?
Is he in neurosurgery?
No, no.
Oh, okay. Okay.
He's an orthopedist.
Okay, good.
John, to support what Dr. Elena was saying in terms of the cisternostomy in trauma in TBI, is true that it's not worldwide well known, which is a great opportunity to have like this kind of meeting.
Hey, here's Iype now. Here's Iype now. So I'm sorry. Go ahead. Go ahead.
To spread the voice in terms of this amazing technique, which actually has made a big step in TBI management, and it's also something else to do rather than the decompressive craniectomy. So that's an amazing opportunity today we will have.
Okay, excuse me, Marco. Takashi, how you doing? Takashi?
Good evening, everybody. I'm Dr. Takashi, come from Tokyo, Japan. I'm a brain tumor. I'm specializing in malignant brain tumor, and I'm eager to add and connect all over the world by webinar, Neurosurgical TV. Today, I'm in the night shift, and it is midnight in Japan, but I'm interested to join this meeting. Thank you.
Yeah, welcome. Hey, Iype. You're muted there, right?
Hey guys, so glad to join you. Elena, hello. Takashi, hello.
Okay.
Yesterday we had cisternostomy when we thought the meeting was actually yesterday. So Giacomo prepared yesterday's case, and maybe he can talk about a few more cases when the brain is much more tighter. So I would watch Giacomo. Giacomo is one of our fellows. He is from
hold on,
Italy.
we'll let us introduce you and everything, okay?
Yes.
Okay, hold on. Okay, 10, ready? You ready, Marco? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Okay, good morning from the Western Hemisphere, and good afternoon and good night for the Eastern Hemisphere. It's a great honor to have today the amazing round from Romania with these amazing neurosurgeons and these amazing topics we have today. So Dr. Madeline, yes, this is your moment. Go ahead and thank you.
Thank you for the presentation. I'm not here yet a doctor, but I hope that soon I will be. First of all, hello everyone. It's so good seeing you all at this very special event. My name is Madalina Popescu. I'm a fourth-year medical student at Carol Davila University of Medicine and Pharmacy in Bucharest, Romania. And I have the pleasure to be the president of this amazing student society, which is Walter Idendi Neurosurgical Club, Romania. I would like to address from the beginning special thanks to the team of Neurosurgical TV, Dr. John Bennett and Dr. Marco Baralt, for streaming us and making our event known worldwide. The topic of tonight's event is quite controversial. We will talk about neurotrauma and TBI management. We will discuss and compare classical procedures with modern methods, such as cisternostomy in TBI. And I would like to address special thanks to Professor Iype Cherian for the honor to have him as one of our speakers today to talk with us about this innovative procedure in the area of neurotrauma. I will not go any longer, and I let my colleagues introduce you in the world of TBI and the classical procedures done in this area, especially the decompressive craniectomy. The first presentation will be held by Ana Maria Zidaru, who is a second-year medical student at Iuliu Hațeganu University of Medicine and Pharmacy in Cluj, and a very important and active member of our club. Anna, whenever you're ready, you can start your presentation.
Thank you so much, Madalena, for the kind introduction. Thank you, everyone, for being here. I'm going to share my screen, and I hope that everyone can see it. Is everything okay?
Yeah, perfect. No, actually, it's not on presentation mode.
Okay, let me.
Yeah.
Is it?
Yeah,
so,
that's perfect. Perfect.
Lovely. Okay, so hello, my name is Anna. Thank you, Madalena. You have already introduced me. So I'm just going to jump right in and start talking about the first topic of today, decompressive craniectomies in TBI. So let me. Oh, I can't move the slide. Oh, there we go. We're going to start with some general notions about what TBI is, and then I'm going to go a little bit into the role and efficiency of decompressive craniectomy in treating it. So traumatic brain injury, or TBI, is a disruption in the normal function of the brain subsequent to disruption in its normal morphology. And there are 4 types of head injuries that can cause TBI, namely direct impact, when we hit our head on something hard, sudden acceleration and deceleration when somebody hits the brake too hard and gets into a car accident, penetrating injuries such as bullet injuries and blast injury caused by explosions. And in this lovely GIF, we can very clearly see the mechanics of getting a brain injury. So due to inertia, the brain is going to hit the skull very hard, and this will lead to the injury. So to jump a little bit into epidemiological stats, around 18 to 250 per 100,000 persons per year suffer from a TBI. And to put it into perspective, around the globe, around 69 million people yearly suffer from a TBI. Most affected groups are men, people in less developed areas, young adults, and the elderly. And now to categorize types of brain injury. So they can be focal. These are direct brain injuries, such as contusions, brain lacerations, hemorrhages, which lead to hematomas, of course, and diffuse brain injuries, such as those caused by sudden movements. So to explain a little bit the outcomes of each type, from the focal ones, we can get hematomas, intracerebral hematomas, epidural hematomas. These on the CT scans will appear convex, or subdural hematomas, which will appear as concave. And the diffuse axonal injuries, these are caused by various mechanisms. So during the hitting of the brain, the axons can get stretched to their breaking point and literally rupture, or the mechanical force will activate sodium channels. Sodium will get into the axons and the neuron, and this will activate calcium channels. When calcium gets into the neuron, this will lead to apoptosis due to its neurotoxic effects. Now, we can also classify traumatic brain injury based on its severity into mild, moderate, and severe. And we can assess these states by looking at imaging, assessing consciousness, and patient memory. But a very important tool is the Glasgow Coma Scale. For mild, the patient would have a score of between 13 to 15. For moderate TBIs, it will be between 9 and 12. And for severe brain injuries, it will go below 9, so 8 and less. And just so we're all on the same page, if we have younger students with us and they're not very well accustomed to the Glasgow Coma Scale, I just want to go over a few details here. So the minimum score on the GCS is 3 when the patient is brain dead. When the score is under 8, the patient is comatose. The maximum score is a 15, which we would all get because we are aware and conscious. We can spontaneously open our eyes. We can produce coherent verbal responses and motor responses. So now going into the role and efficiency of decompressive craniectomy, we have to first understand a few mechanics about traumatic brain injury. So traumatic brain injury often leads to hematomas, as we have seen, and bleeding into the brain basically will cause increased intracranial pressure. So in short, this will compress the brain and produce compartment syndrome. Now, our brain can't go anywhere but downwards. And what will happen is that it is going to press on some very important structures, such as the brainstem, cranial nerves, for example, the vagus nerves. And these structures are so important because they control respiratory rate and heart rate. Putting a lot of pressure on them is going to lead to the death of our patient. Now, we want to use decompressive craniectomies to create more space for the swollen brain so that instead of going down, it has space to swell and go upwards. Thus, we prevent further injury and complications. To further delve into this subject, I thought we would have a little look at the mechanism of how this happens. So we're going to have a little look at cerebral perfusion pressure. So this parameter is defined as the difference between mean arterial pressure and intracranial pressure. When we have a traumatic brain injury, we will have intracranial pressure rising up. So because we are subtracting this will mean that the cerebral perfusion pressure will go down. Our body does this amazing thing to maintain homeostasis and will increase mean arterial pressure to combat the reason intracranial pressure. However, this will mean that more blood gets to the brain and the vessels will bleed out even more. So this further increases intracranial pressure, it further decreases cerebral perfusion pressure. And again, our body reacts by increasing mean arterial pressure. And I think that by now we don't need to repeat the cycle again. We can see that this cascade of events will inevitably lead to what we discussed earlier. So a lot of compression and pressure on the brainstem and the death of the patient. So we are going to quickly look at some common practice, common knowledge about how to conduct craniectomies. And then we're going to look at some very important randomized control trials, their results, and how they influenced today's guidelines for decompressive craniectomies. So some indications for performing decompressive craniectomies are doing hemicraniectomies for unilateral lesions, and bifrontal decompressions for diffuse edema with no obvious midline shift. We want to do early decompression in severe head injuries where the patients do not yet have brainstem dysfunction, and late ones were considered and still are considered to have better long-term outcomes. For contraindications, it is not advisable to perform decompressive craniectomies if the patient has a Glasgow Coma Scale of 3, a post-resuscitation, if they are older than 65, if they have suffered devastating trauma with little chance of survival, if they have irreversible systemic disease, if we have not managed to control their intracranial hemorrhage for more than 12 hours. And we can also look at some useful parameters such as oxygen, arteriovenous difference, and brain tissue oxygen to help us with our decision of doing the decompression or not. And now to look at our randomized control trials. The first important trial I'm going to present is the DECRA trial. This was done with 2 groups of patients getting early bifrontal decompressive craniectomy and patients getting normal standard medical management. So on this graph, we can see that at 6 hours and forward after the decompressive craniectomy, the intracranial pressure goes down. So short term, this technique works and it's good at helping patients. And when we look at the results after 6 months, again, the group that had undergone decompressive craniectomy had slightly better outcomes. However, between the two groups, the mortality stayed the same. And at 12 months, the study reported worse functional outcomes in decompressive craniectomy patients because more of them had gone in vegetative states. And now to look at the Rescue ICP trial. It was a trial done for patients with elevated intracranial pressure. And again, we have two groups, the decompressive craniectomy group and the medical management group. So at 6 months, the study reported better outcomes, but more patients had gone into the vegetative state in the decompressive craniectomy group. And at 12 months, the results are very similar. And on this graph, we can see that the results were assessed using the extended Glasgow outcome scale. Now, this is a different scale, and I'm going to explain it in a little bit. But as we can see, the better results are very similar between the two groups at 6 and 12 months. We can see that, yes, here there are more patients with bad disabilities and in vegetative states compared to the medical group. However, we see less deaths at both 6 months and 12 months. So to go a little bit into the Glasgow outcome scale, the extended version, it is the acronym for this scale is GOSC. It's not Goose, but I thought that it might help people remember that, you know, it's similar to Goose. So a score of 1 on this scale is the worst. It means that the patient is dead, and a score of 2 means they're in a vegetative state. From 3 upwards, we are assessing their disability, and the scores of 7 and 8 mean the best recovery. So from these studies, we have outlined a few guidelines, such as when we should perform secondary decompressive craniectomy, depending on what results we are seeking. So if we perform secondary decompressive craniectomies for late recurrent intracranial pressure elevation, we will have improved mortality and better outcomes overall. This will not happen if we employ this treatment for patients with early refractory intracranial pressure elevation. And if we employ it for both early and late, the results, the immediate result will be visible like we saw in the DECRA trial. It will reduce intracranial pressure and the duration of intensive care that the patient needs. And another conclusion from the studies that is included in the guidelines is that when performing a decompressive craniectomy using the frontotemporoparietal technique, we should go big or go home. So this craniectomy should not be less than 12 by 15 centimeters or 15 centimeters in diameter. And in patients with severe TBI, it helps to reduce their mortality and improve neurological outcomes. And I've just included this image again so that we can see how the frontotemporoparietal craniectomy looks like. Moving forward, so we've done our decompressive craniectomy, our patient is feeling better, but we do not want them to live with this huge indentation in their heads because we care about their mental health, but also because studies have shown that performing a cranioplasty will lead to better recovery. So the cranioplasty will help reestablish normal cerebrospinal fluid circulation and will lead to better brain perfusion. We can do the cranioplasty using bone flap. However, studies have shown that this leads to a significant risk of resorption. So an alternative is using alloplastic grafts. We do not yet know when the best time to perform the cranioplasty after the craniectomy is, but we should perform it nonetheless. And now to end my presentation, I'm just going to say that although decompressive craniectomies are a very old technique that's been saving lots of lives, it has a lot to improve on, and it cannot tackle a key issue that we're going to see presented in the following hours. So it cannot solve edema within the brain. We can open up the skull, but this will not solve the edema. However, cisternostomy is a novel, simpler solution that simply by opening the basal cisterns of the brain will allow for the cerebrospinal fluid to get drained out, creating a pressure gradient so that the edema in the brain parenchyma can leave the parenchyma and get rid of the edema. So with that being said, I thank you very much for paying attention to my presentation. This is my bibliography. Thanks everyone for tuning in, and I'm so excited to hear the next presentations. I hope you are too.
Thank you so much, Anna. It was a wonderful presentation and very easy to understand. If anyone in the audience has a question, please feel free to write it in the chat or just unmute yourself and address it yourself. We'll just wait like 2 minutes. If there are no questions, we'll continue with the next presentation held by our colleague Ana Maria Dragan. Ana is a 6th year medical student at the Carol Dapina University of Medicine and Pharmacy, and she will present us the technique of decompressive craniectomy. Ana, whenever you are ready, you can start sharing your screen.
Hello, everyone. Thank you, Madalena, for the introduction. Immediately. Okay. Can you see my screen?
Yes, but it's not in presentation mode yet.
Yeah. 1 second. Okay.
There you go. Perfect.
Yeah. Today I'm going to present the decompressive craniectomy technique. First of all, decompressive craniectomy is the temporal removal of a portion of the skull for the relief of high intracranial pressure. We can have these conditions in TBI, for example. So, in order to perform this technique, we have some important landmarks that can guide us. For example, the asterion, the keyhole that can help us orientate and see the frontal, the temporal, the pterion, and the ocular fossa, the inion, and the glabella and the midline that helps us avoid the sagittal sinus. I have a video to present. Here we can see that the patient is in the supine position and the incision is made from zygoma to zygoma on the coronal suture. In order to avoid excessive bleeding, we put some clips on the scalp. The scalp and temporalis are retracted forward to expose the skull. We have to protect the eyes from too much pressure. During this procedure, the skin and soft tissue from the superior temporal line to the zygomatic arch must be carefully incised and divided down to the temporalis fascia so as to preserve the superficial temporal artery. Sometimes, in order to fix some dural incisions, we have to harvest the pericranium. So we dissect it from the scalp. Here we can see that the craniectomy is outlined, and we have two slots across the superior sagittal sinus and one just above the orbital region. Sorry, it's here. One above the orbital region and the other one posterior to the coronal suture. Here we have some boreholes in the temporal bone, the thinnest one. And at the end, we flap the bone We elevate the bone to preserve dural integrity with the careful. This is it. There are some complications to the decompressive craniectomy, and we have some recommendations in order to avoid them. The first one is the herniation through the craniectomy defect, and we have to perform a sufficiently large craniectomy in order to avoid it. The second one is subdural effusion, named hygroma. After removal of part of the cranium, augmentative duroplasty should be performed. The third is post-traumatic hydrocephalus. We can employ surgical intervention as soon as possible after the diagnosis of hydrocephalus. We can also have syndrome of the tryphane, and we can perform early cranial repair within 8 weeks after craniectomy in order to avoid this. And the last one is contralateral hematoma. Operation and early detection and intervention are the keys in the management of this complication. Here we have a unilateral frontotemporal parietal craniectomy, another type of craniectomy. And I made a parallel between craniotomy and craniectomy because these terms are usually misused. Craniotomy is the procedure where the neurosurgeon removes a small section of skull to provide access to the area of interest. Before the surgery is over, the bone is replaced and secured with titanium plates and screws. A craniotomy is typically performed as part of another procedure, providing a temporary view through the skull. Craniotomies are common as part of surgeries to treat brain tumors, vascular malformations, and many other conditions of the brain where access is needed. On the other side, a craniectomy is similar to a craniotomy, but the primary difference is that bone is not immediately replaced. In this situation, a secondary surgery named cranioplasty typically occurs once the swelling is gone. A craniectomy is typically needed in an emergency situation, such as a TBI, for example, where a section of the skull is removed to relieve pressure. However, a craniectomy may also be necessary if there is a tumor within the bone itself. When this occurs, the cranioplasty needs to be done during the same surgery as the craniectomy. And I have also another video for this. So, sorry. I told you about the cranioplasty. This procedure is involves replacing the bone after a craniectomy. If the bone has been removed during a craniectomy, the same piece may be preserved and replaced at a later time. However, if the bone has been damaged due to trauma or has cancer cells present, synthetic materials can also be used. Options include titanium, acrylic, or synthetic bone substitutes. Modern 3D printing technologies are also used to create replacements that are perfect fit. And the video that I told you about. Here we can see that the bone is replaced with a mesh. The mesh is approximated around the bony opening and cut using a metal scissor, which can tailor it into the appropriate size and shape. Here we can see that we put some screws to secure the mesh. We do this in a gentle clockwise motion, starting with the corners first. And after that, we place bone cement in order to provide additional reinforcement. This is done in 2 to 3 minutes in order to prevent the cement hardening. And this is my bibliography. Thank you.
Thank you so much, Anna. I really liked your presentation with the very educative videos. If there are any questions, feel free to address them in the chat or live by unmuting yourself. If there are no questions, we'll continue with our next presentation. Dr. Giacomo Bertolini is a Cherian Fellow of Professor Iype Cherian, and he will present us a clinical case of TBI management, including cisternostomy they performed just yesterday. So, doctor, whenever you're ready, you can start your presentation.
Can I share my screen?
Yes, Anna, please.
Okay, let me get Anna
You're sharing your
off
screen
of
and. Okay.
Okay. Can you see the presentation?
Yes, can you put it on presentation mode, please?
Yeah. First of all, thanks for the invitation. I'm very glad to be here and have the opportunity to present this very interesting technique that Professor
Excuse
Cherian.
me, do you want to put it on presentation mode? Okay, that is not on the mode yet.
It's okay?
Not really. You
full
can make,
screen if you can.
please explain it to them how to do it.
Or maybe this one.
I think you should share your whole screen and not just the.
There you go. Perfect. Perfect.
Perfect.
Okay. So as I said, it's a very pleasure to be here and have the opportunity to present this fantastic technique that Professor Cherian invented some times ago. So the main topic is about the CSF shift and explaining the rationale that is at the base of the cisternostomy, this new technique for the treatment of traumatic brain injury. So as I've presented the other colleagues previously, the traumatic head injuries is a very diffuse problem worldwide that very high case load and for which the main therapies have been the decompressive hemicraniectomy that was presented at the beginning of the 20th century by Cocker. So the basic principle at the base of this technique is just to remove a portion of the skull to create more space and the relief of the intracranial pressure. And that's at the beginning one of the preamble to the subsequent Morrockelli hypothesis. However, the decompressive craniectomy it's quite always seen as a last and desperate treatment when all the other therapies have failed. As we can see from previous papers, the decompressive craniectomy is reported as the last therapy in the staircase approach, and this could be also seen in the results because, as we can see here, as presented previously, the results of the rescue ECP trial. If you can see, there is no differences between the surgical treatment and the medical treatment regarding the good functional outcome after the decompressive craniectomy and the medical group. So the question that lead to the discovery of this technique is we have to know if some microneurosurgery it's possibly involved in the management of the brain injury. And to answer this question, we have to make some passages in the pathophysiology of the CSF dynamics. And we need to do a paradigm shift between the Morrockelli hypothesis to this new vision. So at the base of this vision is that there are some spaces called Virchow-Robin spaces that are just in between the basal, just between the vessels and the brain. So an extension of the basal cister that extends into the brain parenchyma. In the physiological state, they play an important role in the transport of the molecules and the cleaning of the CSF and the brain parenchyma. As demonstrated, this is continuous exchange between the CSF and the interstitial fluid as the arterial pulse push this CSF all through the brain and then is reabsorbed through the lymphatic vessels. Here we can see a beautiful representation of this theory as we can see here the vessels from the basal cister that go through the brain And another theory that is also involved in this new vision of the CSF dynamic is the cooling of the brain. As we can see here, all the cisterns are really close to the parasynal sinuses that during the breathing can cool and cool the CSF, and then this cool liquor could spread all over the brain, as has been demonstrated and published in many chapters. So we have seen the situation in normal condition, but what happened in pathological ones? So when a TBI occurs, as we can see here from this picture, the cerebral cisterns start to swell because here we can find some blood or some other, mainly blood. So it starts a positive pressure inside the basal cistern that push the CSF all through the brain, causing the brain swelling. And another interesting thing is, if we can see here, is that when we saw brain CT where the basal cistern are completely full, we can ask ourselves where have gone all the CSF, all the liquor. And the answer is in the brain, because as I mentioned earlier, this liquor spread all over through the Birkhoff space and is inside the brain. There are, of course, many evidence about this theory. In fact, we can see here on the left side an example when there was a dye infusion inside the ventricle. And after a while, if we take specimen of the brain, we can see that the dye it's already it's all in the near of the ventricles and not inside the brain. While if we do an interstitial injection, we can see as all the dye is inside the brain. So this is a proof that this theory is supported by results. And maybe you can also hear.
Actually does so along very specific anatomical structures. There's a specialized anatomy that allows the CSF to move very quickly and very deep into the brain, exchanging with the fluid that's inside the brain and then moving out. So it's a much more efficient system for clearing the fluid and the weight. Actually does so also.
As we can. Also, there are some experimental evidence about this theory. We can see just inducing a TBI in rat models, and we can see as after the induction of the trauma, comparing the intensity on the MRI images, we can see as post-TBI, the intensity of the brain, its sensitivity higher compared to the previous ones. Moreover, if we go on the histopathological section, we can appreciate as after the induction of a trauma, of a subarachnoid hemorrhage, we can find also the blood inside the brain and not only in correspondence to the cistern space, to the subarachnoid space. And we can see here also a dilated vessels of the Virchow-Robin space. So here also we can appreciate the cisternostomy theory. When there is an increased pressure inside the cistern, the brain also starts to swell. So the technique to reduce this pressure is to relax, to open the cistern and allows the brain to relax. Yeah. What about the definition? The cisternostomy or letting out CSF from the basal cistern is a microsurgical procedure that reverses the direction of the CSF shift, decreasing the brain swelling by reducing the pressure inside the brain. Inside the brain. The surgical steps of the cisternostomy is to perform the decompressive hemicraniectomy. The flap could be the same as previously described, but we have to turn the head along the anterolateral scar base, and allows us to reaching the base and open the Leyquist membrane and putting a drain. So this is a procedure that seems easy reading this, but it's not so easy because it's necessary to have an adequate training to perform that, as many difficult procedures such as the transcavernous dissection, the craniectomy could be necessary to perform this type of surgery. Another key concept of the cisternostomy is the unlocking concept. We have to perform an unlocking of the brain into the axial and to the sagittal planes. As the brain is folded in 3 dimensions, and the unlocking should be performed always on the axial and on the sagittal. To perform the sagittal unlocking, we have to remove the sphenoid parts of the bone, and then to perform the axial unlocking, we need to cut the orbitomeningeal band, and we can see better in the anatomical description that will follow. The sagittal unlocking, again, is once we have opened the dura, or we can do also extradurally, main extradurally. We have to drill the sphenoid ridge and the temporal bone to gain an access to the basal cistern and to unlock the sagittal plane. On the other hand, we have to do also the axial unlocking after the sagittal, dissecting the meningoorbital band, as we can see here. Once the brain is unlocked, we can easily access the basal cistern and the basal skull base, and perform a transcavernous dissection to gain a better control of the skull base. Also, some other procedure could be also applied as the anterior craniectomy, posterior craniectomy, but it's not required in every case. And all these maneuvers should be reserved, as you can see here, in complex cases. The surgical expertise to perform this procedure is quite high and necessitates an adequate training. We can see here intraoperative photo of the performing of the cisternostomy. Here you can see the concept of sagittal unlocking when the sphenoid ridge has been drilled out, and we can appreciate here the frontal and the temporal dura. Then, when we have performed the sagittal unlocking, we pass to the axial. Here you can appreciate the meningoorbital band, superior orbital fissure, and always we need to cut this membrane, this dura reflection, to gain access of the skull base. Subsequently, after unlock the axial and the sagittal plane, we have access to the cavernous sinus region, and we can just peel it away to have a much more higher exposure of the skull base. And on the right, we can appreciate also the anterior cranial process that should be drilled out in case of need. Once we have performed this procedure, we can or open the dura and appreciate the internal carotid artery, and also as you can see here, the optic nerve. Then we should try to focus on the opticocarotid space to reach the basal cistern, to opening the cistern and allows the CSF to come out. As we can see here, another image, we have the posterior clinoid, the membrane of Willequist that has been opened, and the P1 segment that comes from the basilar artery, and of course the carotid. Then the catheter should be inserted between the optic nerve and the carotid to gain access to the basal cisterns. Here we can appreciate an operative video of the case of yesterday, as previously described. We can see the CT of the patient that came to us with traumatic brain injury, and when his neurological status started to decrease, we decided to perform a cisternostomy. Here you can see the incision and the positioning of the patient inside the OT, and the main surgical steps. We have to incise the muscles, as you can see here, remove the pericranium, just in case it would be useful later. Okay. Incise the muscles and perform 2 bar holes, usually one on the keyhole and one posteriorly. Then we have to use the craniotome to perform the craniectomy and remove the bone flap. At this point, we can remove, perform the sagittal unlocking, removing the sphenoid ridge, as you can see here, drilling it. And then once the drilling is completed, we can perform the meningoorbital band detachment for the axial unlocking. Here you can appreciate the anterior clinic process that should be removed to gain a better exposure of the basal skull base and to gain a wider corridor for the procedure. Then we open the dura and prior to the evacuation of the subdural hematoma, we can just follow and reach, we can appreciate here, the internal carotid artery and the optic nerve. Then we pass laterally. You can appreciate here the third nerve, and we can open the cistern with a sharp instrument. Open the iliac membrane and reach the basal cistern. You can appreciate here the basilar artery. Then came back to the opticocarotid space for a wider opening of the cisterns. And at this point, we should put the drain to complete the procedure. Here also you can see the postoperative CT of the patient without any edema or shifting. Here is another case. You can where the brain was more contused. You can see here the brain after the opening. It's very stiff, very tight due to the contusion. Then going down, we can appreciate here the optic and the carotid. Here is the space that should be open to reach the iliac membrane that need also to be open to access the basal systems. No. Okay. No. And not working. Just to see that at the end of the procedure, once the drainage is inserted, we can appreciate the pulsation of the brain, that it's very unusual with the common technique after the removal of the hematoma. Here. But what after discussing the technical procedure, we should also talk about the indication to perform cisternostomy. Of course, should not be performed in every cases, but we will see. The main topic is that the TBI, it's a dynamic disease, and there is a narrow time span for the decision when to do the surgery and if to do the surgery. According to the experience that elaborate a score, when there is a drop, there is a neurological deterioration associated with sign of ipsilateral cerebellopontine center widening, cisternostomy should be proposed to the patient to prevent the brain herniation. So in every case of brain swelling, as you can see here, bilateral contusion with or without subdural hematomas, in case of impending herniation, same through the oculomotor nerve palsy, this procedure should be considered. And also, there is a cisternostomy indication score that can allow and help us into decision to performing this cisternostomy. You can see here that according to the neurological status, the pupil status, and the system on the computed tomography, we can elaborate a score that can guide us in the treatment. Of course, when the patient is very, very bad, when the motor score is very low, as the pupils it's dilated and non-reactive, and there is no system, the brain is completely herniation. There is no indication to perform this surgery because it's impossible to come back from this condition. But in case of patient that it's deteriorating, we should ask the patient if cisternostomy could be indicated. However, some contraindication exists, of course, when the age is very high, in case over 80 years old, it's maybe contraindicated, or maybe also in case of polytrauma, prolonged hypoxia, prolonged severe hypotension, systemic complication, and of course the diffusion axonal injury. In case of ischemic, it's questionable, despite some evidence suggests that also in this case, the cisternostomy could have an indication. I don't know if the professor wants to explain some clinical cases.
Giacomo, you can carry on showing those images, actually. I mean, these are some cases which we would like to show you. These, I mean, only thing I can say after Giacomo's excellent presentation is that many of these cases, if they were done DC, we have seen these experiences. They are these cases which we are going to show you, the results would be very, very bad. there are some cases where DC would work, and I would say those were cases probably where nothing, medical treatment would have sufficed actually. But those tight brains where when we go ahead and do DCs, we have done enough of them. I mean, as a resident and as a young consultant, about 15 years back, we had an experience of over 700 decompressives before we started microneurosurgery for this, all those almost accidentally. And over 15 years, we've seen what is this drastic difference between microneurosurgery versus a surgery that is over 100 years old and founded on its foundation is on a wrong statement, as Giacomo showed. Now, we can show you some scans, but more than anything, what I would ask the young people to do is, you should change. It's very difficult to change, especially when you've been told something for 4 generations of neurosurgeons who's been telling you that there's nothing except in trauma, there's nothing except just open the bone flap and throw it out, and then come back and put in a bone flap. If he survives, come back and put in a bone flap later on. There's nothing far from the truth than that. So microneurosurgery, opening of cisterns, although it's difficult, it definitely works. And there's a lot of evidence right now. There's a randomized control trial right now. And there's so many trials coming up all over the world. It's accepting. 15 years back, it was not the same. When I said this 15 years back, things were hostile, much more hostile than now. But we don't have any agenda. Our agenda is to improve microneurosurgery in the rest of the world, everywhere, so that a neurosurgery resident should not be doing this 100-year-old surgery, where Cocker would have been okay to do it, because Cocker is from 120 years back. You go back 5,000 years, they were putting holes in the head to, cure, to let out your spirits. That was right at that time. Maybe Cocker was right at his time. In 120 years back, we didn't have a plane. That doesn't mean that we don't fly now. 120 years back, we didn't have automobiles proper automobiles. Okay, we had horse carriages. So it doesn't mean that we have to go on the same horse carriage again. All the rest of the neurosurgery has changed, but since trauma is emergent, which means trauma comes at the late hours of the wee night. And just because it is the largest neurosurgical load in the world, 5/6 of the world is developing or low and middle income country classified. And there's absolutely no excuse for considering this neurotrauma as something secondary and not bringing microneurosurgery into it. So this would be our message. If anybody is interested in the scans, we can send it to them. But thank you very much, Giacomo. Fantastic talk. You have probably said it better than what I would say. Thank you very much.
Yes, I would like to give an amazing greetings from far from where I am right now, and because your work is so far well known because of the amazing outcomes that comes from that technique, and where I come from, which is the Western Hemisphere in Latin America, we haven't had this amazing tool to provide it to the patient. And I think it's a great opportunity to have this into account and start to develop it in our countries, because it's going beyond the decompressive craniectomy. It's not just staying, as you said, it's not just staying in the simple technique, removing the screw, and that's it. No, it's going beyond that. Is having into account that there are physiology happenings in the brain that actually can work if you do something else, for not only for the pathology itself, but the patient, because eventually the patient will improve from it. And I will thank you for the amazing lecture, and from this opportunity of hear your expertise. Thank you very much.
Thank you.
I'd like to thank you to Dr. Giacomo Bertolini and Dr. Iype Cherian. Your work is truly amazing, and we should all thank you for the opportunity to be able to talk about cisternostomy in TBI, because one of your contribution to the field of neurosurgery is this innovative procedure that truly amazes us. So we'll go on with some clinical cases, or what will be the next presentation?
Well, if you want, we can show you some clinical cases. It would be interesting because these are cases I can explain to you. And Giacomo, will you share your screen, please?
Yes.
Yeah.
Yes, for our students, it's wonderful to see clinical cases, and they
yes.
educative for us.
Can you see the screen?
Yes. Can you maximize? Yeah, this is maximized, right? So this is a case which was, I remember this gentleman. He was, his left pupil was dilated, and you can see there's absolutely no space. You see, the cisterns are completely closed off. The brain is getting, the brain is under tremendous pressure. So there's a paper which says that when your cisterns are not seen, that the ICP is above 25. So you really don't need to go ahead and put in an ICP to measure it, because you know that the ICP here is about 25. That's dangerously high. So next. So this guy was done about I believe in maybe 2012 or something, very early in our cisternostomy surgery. And here we used to do, our first 300 cases were decompressives with cisternostomy. And then we started putting a little bit of bone. You can see a little bit of bone there, that's a little bit of thin bone. We used to keep it back because like everybody, we were also not into a paradigm change. We slowly phased it out because I was the first guy doing it, and there were not much support. I couldn't, although I believed in it, I was not sure, because centuries of teaching, 1 century of teaching told me this is wrong. And then I had to fight against it from my heart and say this is right. And I had to go for it. Here you can see that all the cisterns have opened up. Do you have a video of this guy, Giacomo?
Was not working.
Okay. So there's a video of this guy just walking around. You won't believe it, but there's a video of this guy and telling his name just before he's leaving from the ICU. So this is what we wanted to show you. This is the effect of opening cisterns. See this one. You see the midline shift on this one. The midline shift is so much that a little bit more midline shift and the midline will be out of the head. Okay, that's the kind of midline shift we have. Massive head injury, very bad. The CPI angle cistern is completely widened. This means that there's herniation. There's herniation happening. Okay, and this is a guy who came to us, and you see this guy. Okay, nothing. I mean, see the post-op. Post-op, next one. Yeah, see, no decompressive done. The bone flap is kept back. The midline shift is improved, but see the guy. Okay, next. Yeah, this is a VVIP patient. I remember this one also. These are my earlier ones. Now we have over 1,500 and all the consultants are doing it. So I'm no more involved in it right now. But unless there's a very difficult cisternostomy, a type C cisternostomy, I don't come into the picture. So sometimes I do it so that I don't forget it, but otherwise it's all the consultants doing it. So, but these are my earlier ones. So I remember each one of them. This was, she was related to the national football captain. So she was choppered in to our center, and pretty bad. GCS was 6 and left pupil was dilated. There was severe tentorial herniation. We didn't do a decompressive, just post-op pic, please. Yeah, so this was a post-op pic. She's discharged. She was 14/15, and but now she's driving a scooter around. I mean, he is driving a scooter around. So, I mean, this made me friends with the Nepalese national football team captain. So, I mean, that was not a bad deal because we could, go to any showrooms with that chap, and you can imagine he was a big celebrity. So he is still very good friends with me. So this was, but you see how bad this, was. If you had done a decompressive here, I'm sure the football captain would have been not in very good terms with me. So next one. Yeah, you can see how bad this one is. So this is a lady, I still remember very clearly 10 years back or something. I was in the emergency and this lady was brought in with bilateral fixed pupils, okay, dilated. And you can see almost, you can see I mean, on the third image, second row, you can see there's brainstem hemorrhages also. That's what it looked like. So we said, there's nothing to be done. So the lady's husband had a small child with him and he said, do whatever you can. So we went ahead and you see, this is a retraction injury. Some people go ahead and criticize it saying that, oh, you had retraction injury. And this lady had a permanent third nerve palsy because she had herniated, obviously. It was a very, very tight brain, but she'd see her. A decompressive hemicraniectomy could never have achieved this. No other surgery except this would have achieved this. She is a housewife now. So she's working, she's taking care of her daughter. Her daughter is big right now, maybe 10 years plus. So, and this was what happened. So it is, I mean, I would say it is impossible to even imagine with the decompressive. You look at that previous scan and you'll understand. Next. Yeah, so, yeah. Next one, see this one. See how bad is this one. And if you do a decompressive, I mean, this one was very, I mean, that's just four years back, I guess. I mean, it's in Nepal. So I remember this lady coming back to my office completely okay. I think this was done by one of the consultants. So next picture. Yeah, so this is her. So he's coming back to my office to say thank you to me. So next. Yeah, so, well, I remember about 1,500 cases, and after that I've lost count. So we were in a pretty busy center in Nepal now, but now Parthiban has maybe more than 150 cases. Wang has more than 300. And the Brazilian group has a lot of cases. Europe, Switzerland is doing a lot of cases. So it's, I mean, China, India, everywhere they're doing it. So it's catching up. The thing is, there are old neurosurgeons. I can't blame them for their attitude. It's maybe if I was a bit too much old, I wouldn't have accepted such a fancy thing. And, I wouldn't have changed myself. Maybe, I don't know. Till now, I am flexible with my mind. So my mind is always open for new ideas, but maybe there will be some point of time where I would say, no, that won't work. I've got enough experience and that's not going to work. And the sad fact is most of these guys don't go to theater at all. I mean, for trauma at least. And most of the trauma neurosurgeons hardly go to the theater. They play around with p-values. And it's not an insult to them, but that's how the sad affairs are, because they analyze, they are paper tigers, as Juha says. They analyze the results of something which is done by a junior resident, and they project these p-values and they say there's no hope. And they want it that way. They want it that there's no hope, because that's the only time they can, they can be the top in trauma surgery. If the youngsters take charge and say that microneurosurgery is trauma surgery, and microneurosurgery better than aneurysm surgery, better than, you ask Giacomo, he will tell you that The way we exposed the basilar, the way we exposed every single vessel is just like you would go clip a basilar tip aneurysm. Exactly the same technique, exactly the same kind of drilling, exactly the same kind of patients. No running, I mean, no hurrying, no shortcuts in these kind of surgeries. No margin of errors, no mistakes. You make a mistake, then just like an aneurysm surgery, you'll pay for it. So, but this is the thrill of microneurosurgery. You must understand, you know, my daughter plays these games with, I mean, we play a game on this phone. There's a bonus round. It's very easy. So the bonus round is very easy. So, but we say the bonus round is not what's important. The real round, which is really scary, is what's important, you know. That's why we are neurosurgeons. That's why we've chosen to do neurosurgery, not for the easy way out. So I would want all of you, each one of you, to take up microneurosurgery, boldly say that it is better than a 100-year-old surgery, and not give excuses of we don't have microscopes, we don't have. In Nepal, I didn't have anything to start with. So Nepal is one of the poorest countries, if you know. I'm back in India and I see the difference, but in Nepal, 14 years of my cisternostomy was in Nepal. So we got everything. We got everything. If I'll tell you, I always tell all the young neurosurgeons, if you say you don't have a microscope, sell your car. Sell your car, get your microscope. Okay. Because this is after your wife or your girlfriend, the next important thing is neurosurgery. This is what you're doing. Okay. So sell your car, I mean, I won't say sell your house, your wives will, you know, kill you, but at least sell your car. Okay. Sell your car, buy a microscope and get going. Get your microsurgical set, get going. All the best. So thank you very much for the opportunity. And I hope someday I'll see one of you guys sending me a WhatsApp picture of the cisternostomy that you've done. I get a lot of these pictures these days, and it makes me very proud. So I hope someday I'll get a picture from you guys saying, this is the cisternostomy that I've done, and the patient is doing well. So thank you very much.
Thank you so much, Professor. Your presentation was truly wonderful. And I hadn't had the chance to present you at the beginning, but I think everyone in this meeting knows you, and your work is truly amazing. You amaze us, and you are a model for us. So we have actually a question from the audience. How do you deal with the traumatic burst lobe bifrontal intracerebral hematome? Did you cut the fossa for better decompression?
No, if it's we just had a bifrontal subdural with a condition on one side. We do cisternostomy on one side. Both the brains are actually communicating. So, I mean, unless there's a very large contusion or a very large subdural on the other side, we don't have to cut the fossa or anything. The fossa is just incomplete partition. It's not a partition which is complete. It's like a half door. Okay, one of those peeping doors where you can see the action, all the action outside. So the fossa is not a complete door. So you don't have to cut the fossa. You just do cisternostomy on one side and be okay.
Okay, thank you so much. If there are any more questions from the audience, feel free to ask them in the chat or by unmuting yourself. If not,
somebody is asking me, what is the learning curve to perform a cisternostomy for a neurosurgical resident? Can this be implemented in residency training? Yes, of course. Of course. So we have a resident who is now ready to, you know, he is finishing his training and he's ready to perform cisternostomies. Of course, it has to be trained. It has to be like that. It is a false belief that neurosurgical residency should be just the beginning of things. No, it should not be, because most of our countries are not very rich, and we need these neurosurgeons to go out there and start doing surgeries. So yes, for sure, it has to be implemented in your surgical training, but you got to put in a lot of hard work for this, because this is hard-earned skills. These you have to go to the lab, cadaver lab, and train how to do an anterolateral, sagittal unlocking, axial unlocking. You have to understand the concept, and you have to have skills with microsurgical dissection of vessels, arachnoid opening in tight brains, of course, and you have to have the attitude. You have to understand that these tight brains can be dealt with. You don't have to throw up your hands and say, oh, I can't deal with these brains. No, you can, you really can. So Giacomo is seeing all that right now, and I'm sure we've had a lot of fellows over the last 4 or 5 years, and his senior Andrea has already done cisternostomies. He's back in Italy. He's already done cisternostomies. So we've got a lot of fellows who go back and do cisternostomies, and of course, I believe that in residency this should be part of the training.
Thank you so much for your answer. If there are any more questions.
I would like to make a small comment that it's incredible, Professor, how this new technique has changed the entire perspective of how TBI actually works and the impact of the TBI on the brain. Because normally we used to believe that the impacts of the intracranial pressure was mainly against the ventricles and the CSF inside the ventricles, rather than right now with this new perspective, we know that the basal cistern has a more important role in the management and control of the intracranial pressure. So I was reading one of your articles, one of your amazing articles related to that catheter you put in front of the prepontine cistern, which will able to measure the pressure actually in the basal cistern, which, as you said before, it will be a more accurate data for us to manage rather than intraventricular catheter. So that's changed the whole world, neurosurgical world, in terms of how to manage properly the TBI, because it was quite hard to put a correct catheter inside the ventricle with the patient with TBI, because we know that the compression of the ventricle may make like a slit ventricle, and it's quite hard. And we we still trying to put the catheter inside the ventricle. Rather now with this technique, that we actually know how the CSF flow changes. And because of that, because of the technique that actually opened the basal cistern and allows the CSF flow, it allows us to know that the main problem wasn't inside the ventricle, but was outside. And that's something that I have to give you a great comment on that, because it's really amazing.
Thank you. You must know that the CSF is an amazing mechanism. It's the more we think about it, the more intriguing it is. Do you know that CSF is used to cool and clean the brain? So we put that theory forward in 2013. It's used to clean and cool the brain, and our sinuses, our nasal sinuses, are lined with wet mucosa. And when we take deep breaths, what happens is, today I was in the rain. I was just coming back from my farm, and we were in the rain, and we were sitting in front of in the window in the car, and it was making me very cool. So it is the same principle. When you're taking breath, these sinuses which are lined with wet mucosa is cooling. And remarkably, the cistern, the suprasellar cistern, the largest collection, is right in the middle of these sinuses, which are getting cooled. And more remarkably, there are all the vessels in this cistern, and they are going from the cistern into the brain. And these vessels are pulsating. And when they pulsate, the cooler CSF goes into the brain, cooling the CSF. So the sinuses, they are cooling the brain actually. It's amazing. And then in the night when we sleep, the aquaporin 4 channels open up, and this CSF also goes into the cells, cleaning out the lactate, the chloride, the ammonia, everything. It cleans up. So it's a cooling and cleaning is done by the CSF. So we proposed that. And of course, we didn't have a basic science research lab in Nepal, but then we proposed that. And then we wrote a paper of this hypothesis. Now it's proven. I mean, there are many papers which proves all this. So I would say again, mind is your biggest lab. Okay, mind. If you have a very inquisitive and childlike mind and you keep asking questions, there's a lot of things you can do. This is how science progressed. Only in the last 50 years, we've got all these basic science research and evidence-based stuff going up. And, you know, we had just a lot more original thinking much before that. So I want you guys to give an equal importance to the mind, and think more, ask questions more, and then you'll progress more. You'll be happy for you. I mean, I'll be very happy if you can do that.
Thank you. Thank you very much. I would like to invite, because we are doing Cuban ground rounds, because I'm from Cuba. We are doing like a Sunday conference, and I would like to invite you to give us one of these amazing lectures related to cisternostomy, because it would be really amazing if countries like us, like Cuba, Latin America, South America, where am I right now, start to change, first of all, the perspective of 40 years old or 80 years old neurosurgery related to TBI. That most of the trials that never up to 2020 have spoken about cisternostomy. And I think it would be an amazing opportunity for our countries to hear your experience, your experience, and this new opportunity that we have to offer to the patient. And I think it would be amazing, Professor.
I'll be honored. I'm coming to South America this November, so let's see how things work out.
Very good. Let's show Iype what's coming up here tomorrow, actually. Can you see that okay?
Yeah. Oh, Vinso.
Yeah.
Ali.
Yeah, Ali Chris is speaking. I knows him well, I'm sure. He's speaking tomorrow with Binzu at 8 o'clock China time, PM. And Marco is hosting the Cuba Grand Rounds. Maybe you can go over the speakers real quick, Marco. Can you go over them real quick?
Yes, of course. There is no problem with that.
Do you want to discuss the speakers briefly?
About tomorrow?
Yeah, for tomorrow. Yeah, can you see the screen okay?
Yes, I'm seeing it, yeah. Yeah, I'm seeing it. Yeah, tomorrow we have 3 conferences from 3 different neurosurgeons. The first conference is related to minimal invasive neuro-oncology from Dr. Pegues, which is an amazing young neurosurgeon, which she did a fellowship in neuro-oncology. And the second conference is going to be given by Dr. Omar, which is a PhD related to school-based surgeries, and it has an amazing work in terms of the pituitary tumors and craniopharyngiomas. And the third conference is going to be related to spinal surgery, complex spinal surgery, and the first CT, intraoperative CT in Spain by the Dr. Eddie Leandro Almira. So it's going to be an amazing opportunity. It's going to be great lectures, and all of you are invited to.
Okay, very good.
Thank you, guys.
Thanks everybody.
Okay, so we still have one more presentation, one last presentation.
Oh, I'm sorry. I'm sorry.
It's everything okay. But thank you so much for the invitation for tomorrow's event. It really sounds very interesting. But we have one last speaker, which is a very dear person for our club, Dr. Elena Neștian. And she's a neurosurgery resident at Bagdasar Arseni Emergency Hospital in Bucharest, Romania, and actually a former president of our club. And she will present us a meta-analysis regarding cisternostomy in TBI. And Elena, the scene is yours whenever you are ready.
Thank you very much. I'm going to share my screen now. And all right. Is it full screen?
Yes, it's okay.
Yes,
Okay.
Yes, perfect.
Thank you, Madalina, for the introduction. I'm very excited to be joining you today. I am very interested in this topic, cisternostomy, and especially introducing microsurgery in TBI management, which is truly a paradigm shift, and it's something new, something recent. Time will tell how this will turn out to be, but I'm on the pro side of the debate, let's say, because so far it is a controversial topic, but I truly believe that in order to achieve any kind of progress, the first step is to bring the matter into discussion. And my role today is to present you, well, something rather boring for a neurosurgeon, which is numbers and p-values. But as a young neurosurgeon who is in training, or who has never seen a cisternostomy performed so far in Romania, I only had data from the literature. So what I could do as a small contribution was to look at the data published so far and see what conclusion we can draw in 2022, more than 10 years after the first cisternostomy was performed. For those who joined us later, the burden of TBI worldwide is huge. These are the number of deaths annually in the United States only. And when we have a brain injury, there are primary brain injury mechanisms which occur at the time of the trauma, but also secondary brain injury mechanisms which lead to edema and raised intracranial pressure. And the current standard protocol consists only in decompressive craniectomy and inserting an external ventricular drainage. So far we understood that cisternostomy means opening the basal cisterns, which are the subarachnoid spaces surrounding the circle of Willis at the base of the skull, and also the main blood vessels. The challenges that cisternostomy pose are consisting in the necessity to have specialized equipment like microscope and electric drill, and to have them available late at night. And also they regard the skills that a neurosurgeon operating has to possess, which are vascular and skull-based neurosurgery skills. And we all know that there is a steep learning curve. We already talked about the technique, opening the orbitomeningeal brain, opening the dura between the frontal lobe and the temporal lobe, getting access to the anterior clinoid process and drilling it from an extradural approach in order to obtain more space before opening the dura and going straight to the optico-carotid complex, and then going into the optico-carotid triangle to the membrane of Liliequist and the prepontine cistern. So you already saw these images. Let's recap. Here we have the frontal lobe and the temporal lobe. It's a left side approach, the sphenoid ridge. We drill the sphenoid bone. We go to the orbitomeningeal bed, which is incised. Through a sharp dissection, the dura of the temporal lobe is detached from the dura of the cavernous sinus. The anterior clinoid process is seen here. We drill it. Here we can see the carotid artery. And only then, when enough space is created from an extradural approach, the dura is incised as basal as possible. Here is the case of a subdural hematoma, which is evacuated, and then the optic nerve is discovered, the carotid artery, going between them to the membrane of Liliequist, which is incised, and we have access to the prepontine cistern. And then we insert the catheter. I read that the catheter is kept there for 5 days. So going back to the rationale behind this, we have the Virchow-Robin spaces, which we can see here on the T2 MRI, which really is a prolongation of the subarachnoid space. The CSF is hyperintense in T2 MRI images, and these lines that we can see, these arrows pointing at, represent the Virchow-Robin spaces. And we have a theory about the glymphatic system, and the whole theory about a new type of brain edema which occurs in trauma, theorized by Professor Iype, Cherian, which is the CSF shift edema. When the cisterns become clogged with blood, the pressure in the cisterns increase, and through the Virchow-Robin spaces, the brain becomes swollen. But when we open the cisterns and insert the catheter there, we reverse this pressure gradient. So the brain gets relaxed because the pressure in the cisterns is less than the pressure in the brain parenchyma, which is different from the intracranial pressure, is the pressure inside the brain. We have the intraparenchymal pressure on the one side and the intracisternal pressure on the other side. And we have a gradient there. When the pressure in the cisterns is less than the pressure in the brain parenchyma, which we can achieve by inserting a catheter there, we can reverse this gradient of pressures. So this is the whole theory about this. And as we can see in the middle image, cisternostomy helps by solving the problem, which is the edema, whereas the standard decompressive craniectomy does not relieve edema. It only allows more space for the brain to herniate outward. But this leads to a lot of complications, as you've seen from the previous presentation. And this paper from 1 year ago clearly shows in numbers, in measurements, then by performing this and reversing the pressure gradient, the neurologic status of the patients is improved. And here in these graphs, you can see red line is the cisternal pressure, blue line the parenchymal pressure, and with green is the Glasgow Coma Scale of the patient as a measurement of the neurologic state. And as we can see here, as long as the cisternal pressure is below the parenchymal pressure, the Glasgow Coma Scale of the patient is improved. On the right side here, on the other side, you have a rather difficult case in which you can see that for the first days when the cisternal pressure was lower than the parenchymal pressure, the Glasgow Coma Scale was somewhere between 5 and 7. But when the cisternal pressure rose above the parenchymal pressure, the Glasgow Coma Scale dropped. You can see the green line going lower and lower. And in the end, the cisternal pressure is very, very high, and the Glasgow Coma Scale of the patient is 3 points. And all of these results were statistically significant. That being said, let's move on to the meta-analysis. And today in Romania, it's raining, but it's gonna rain all over with numbers. So I performed a systematic search in 3 databases, PubMed, Cochrane, and Google Scholar, using cisternostomy, trauma, TBI in various combinations. And the last search was performed at the end of the March. Duplicates were excluded, and in the end, 38 publications met the inclusion criteria, which is focusing on cisternostomy with the indication to relieve brain edema. So in the end, we had 1 randomized controlled trial published this February, 3 prospective studies, 2 retrospective studies, which were further analyzed in the meta-analysis. Here you can see that most of the papers published on the topic are reviews or editorial papers, a few case reports, 1 technical note, and just 5 prospective studies and 5 retrospective studies. The number of publications per year, as you can see, is on the rise, and we are in June right now. Till March, 2 articles were published, and as I searched through literature, there is another article published in May, a technical note article describing the approach, and as well as giving pictures of cadaveric dissections. This is an overview of the retrospective studies. We're gonna look at them later, and prospective studies. What we analyzed were, of course, 2 major factors: the mortality rate and the outcome, but also the duration of stay in the intensive care unit, days on ventilator, the ICP pressure, the herniation of the brain, and as well as the additional time needed to perform the cisternostomy. And what I did later was to dichotomize cisternostomy into 2 groups. I called one to be adjuvant, meaning that the bone flap was removed, just as in decompressive craniectomy, and the cisternostomy was performed, as well as on the right, standalone cisternostomy, meaning that the surgeon performed cisternostomy, but decided to put the bone flap back at the same time and not leave the bone out. Here you can see the first randomized controlled trial published this year. And I need to say that all the patients included in this paper were meeting the same inclusion criteria, and they were randomly distributed to either cisternostomy or decompressive craniectomy in order to better analyze the results. And the results were in favor of cisternostomy. Moving on, I'm gonna show you a couple of graphs, which for students might be very, very difficult to understand. That's why I've put here a slide on how to read the meta-analysis. So a meta-analysis is a way to summarize in a graph the results from numerous other studies. So when you look at the forest plot, you get a really, really condensed synthesis of what results exist in the literature. Step 1 is understanding the groups compared in the meta-analysis. And when you look at 1, at the arrow, we see that there are 2 types of interventions compared, so clinical and standard care. Then we move on to step 2. We look at the significance of the overall effect. You can see here the arrow, and we'll look at the number here, P, the p-value, meaning when the p-value is less than 0.05, the result is significantly statistic. And when it's more than 0.05, it's not significantly statistic. Next, the third step is to understand the effect size. So when you have a meta-analysis, you're going to include different studies. Some are going to have 100 patients, other one with 20 patients. And here you're going to see the effect of the size of the study population. Here you can see a small effect, here you can see a bigger effect. And consequently, the results published in the study, which included more patients, are gonna have a more impact on the overall effect. Then we see what is the overall effect. We see what is the impact of the intervention. And then we look on the whole at the diagram, and specifically what we're looking at is at this diamond here. And when this line is 1, it means that either choosing treatment A or choosing treatment B, the result is the same. If the diamond is here on this line, it means that there is no difference between those two types of treatment. When the diamond is either on the left side or the right side, it means that one of them has an impact on the course of the patients. So let's move on. The first parameter that I analyzed was the mortality in decompressive craniectomy versus adjuvant cisternostomy. And when we look here at the p-value, it's significantly statistical. And we see here that the diamond is clearly placed on the left side. So the mortality rate was reduced in adjuvant cisternostomy. This is a fraction, so 0.71 means almost 33% mortality reduction in the population in which adjuvant cisternostomy was performed versus standard decompressive craniectomy. And here you can see that this diamond is clearly seated on the left side, and none of these edges meet the vertical line. So it's clearly an effect on this side. Here we can see that also when we compared cisternostomy as standalone procedure, so here on the lower right side, comparing decompressive craniectomy with cisternostomy, meaning that the bone was put back, meaning that the complications of not having the bone replaced, the syndrome of the Trephine, the hydrocephalus, and so on are avoided. The p-value is the same, so it's significant, and the reduction in mortality is even more important. So 33% reduction in mortality versus 50% reduction in mortality. So I would say that this is an important result. Looking at the outcome measured in Glasgow outcome score points, the Glasgow outcome score scale has 5 numbers. So Glasgow outcome score of 1 means that the patient is dead, and 5 means that the patient fully recovered. Here you can see that we have a higher number. So the Glasgow outcome score was higher in the patients in which cisternostomy was performed. And the result is significant. Here you can see that also the Glasgow outcome score was higher in the cisternostomy group, but here you can see that the edge of the diamond is intersecting the vertical line. And here you can see that the p-value showed that the result was not significant from the point of view of statistics. But you also can see here that we have a small number of studies included here. So maybe the result is not significant because there weren't many studies found to include cisternostomy as a standalone procedure. Also, here we can see that the duration in the intensive care unit is lower in the cisternostomy group, both here and here, as well as the number of days on ventilators are lower. And here you can see the brain outward herniation in decompressive craniectomy, which is important, as you can see here. The ICP pressure, the intraparenchymal pressure, is lower when the cisternostomy is performed. And of course, there was an additional time needed to perform the cisternostomy. Not all of the authors reported those. For example, Professor Iype reported 10 to 20 minutes, depending on the complexity of the case in which he needed to perform additional posterior clinoidectomy, of course, led to longer interventions. So coming up to the conclusion, as you can see, cisternostomy, both as standalone or adjuvant, both when the bone is replaced or kept away, were proven to be associated with improved survival and clinical outcome when comparing to the standard decompressive craniectomy. Of course, we don't have a lot of evidence, but I am very confident that over the years, stronger data will support this practice. And of course, we need to have multi-center randomized controlled trials in order to have larger population size, homogeneous data reporting, and to improve the current methodological limitation. But the takeaway message for us young neurosurgeons and residents is that there is a growing need to train in skull base and vascular. Because at 3 a.m. at night, we are going to be the ones at the hospital, and we are going to need to know how to perform this kind of complex surgery. So this is truly a paradigm shift, because it shows that trauma surgery is also complex, and there is a lot to improve in terms of patient outcomes, which is really what our intentions need to be pointing at, improving patient outcomes. Of course, this is an ongoing challenge, an ongoing effort to be implemented on a large scale, and for us to train in order to be able to perform this kind of complex surgery. And just to show you, this is the article that was published this May, and I'm looking forward to reading the next randomized controlled trials that are going to be published in the future. That concludes my presentation. Thank you so much for your attention. I hope I didn't bore you to death. And I know I would like to present you my cases of cisternostomy and not numbers, but I am a second-year neurosurgery resident. This is all I have for now. I hope in the future I'm going to show you patients as well. Thank you so much.
Thank you so
Excellent.
much, Elena. It was a wonderful presentation. And, if there are any left questions for any of the speakers, just please ask them, or you can ask them in our direct message on Instagram. You can follow Dandy Romania, and we'll answer all of your questions or redirect them to Professor Iype Cherian. So thank you all for being with us at this amazing event. I hope to see you soon at our next event, and have a nice day, evening, or morning, wherever you are.
Okay.
Thank you. Go ahead. Go ahead.
Thank you, everyone.
See you. Thank you, everyone. Fantastic meeting. Thank you very much.
Thank you. Thank you to everyone.
Thanks, everybody.
I